السلام عليكم ورحمة الله وبركاته. يعطيكم ألف عافية، ورجعنا مع جديد بحلقة 15 من مع طلال. برجع بقول لكم هاي البرنامج صراحة له كتير أثر في قلبي. كان الفكرة تبعه هي عبارة عن أنه نحاول نبعد عن الأبيض والأسود، ودائما نشرح ما خلف الحالة وشو هي كواليس الحالة. ودائما أنا لازم أترحم على الدكتور ولاء الملا اللي هو صمم لي الانترو، الله رحمة الله عليه، والباقي هو الله سبحانه وتعالى. ودائما بقول انه نحن دائما لازم نعرف خفايا الامور، لذلك لازم دائما نسال عن الحاله ونسال عن تفاصيلها. وهذا الشيء الدور اللي انا بحاول ان شاء الله قدر الامكان اني انا اعمله من خلال الحوار مع احد الضيوف. ضيفي اليوم هو ضيف شخص بالنسبه لي صديق صراحه، الدكتور انطونيوس شانيوتس. الدكتور انطونيوس شانيوتس من اليونان غريس. هو ما شاء الله عليه اسم كبير وله باع طويل في الاختصاص مداواة اللبية. دكتور أنتونيس شانيوتس للي ما بيعرفه هو خريج كلية طب الأسنان بغريس اليونان بعام 1998. بعدين عمل اختصاص 3 سنوات بالإندو وتخرج بعام 2003، ومن وقتها بلش يدرس بجامعة اليونان. ونرجع نقول قديش مهم إنه الإنسان الجامعة اللي يتخرج منها يدرس فيها. وبعدين أيضا حصل على فيلوشيب تيتشر، أيضا بدرس بجامعة University of Warwick باليو كي. هو international member of the American Association of Endodontics، وأيضا active member of the European Society of Endodontics. صراحة عنده publications كتير. هو worldwide international speaker معروف locally و internationally. عنده publications وعنده حالات كتير مميزة وبتدل عليه. عنده أيضا ممارسة خاصة بمداواة اللبية بعيادته بغريس، وأيضا عنده سنتر للكورسز. So he is practicing hands-on courses, delivering hands-on courses in his private clinic بغريس. رحبوا معي جميعا مع صديقي العزيز الدكتور أنتونيس شانيوتس. Hi my friend.
Hello to everybody. Good evening from beautiful Athens, Greece, to all friends that are watching us. And I'm really excited and happy to spend the next half an hour discussing with you a very interesting case that I selected. Thank you for the introduction, and thank you for the opportunity to be with all these people connected online to discuss a very interesting case, I believe, that I selected for this course.
Thank you very much, my friend. Really, we are honored to hear from your side. By the way, Dr. Antonis Chaniotis is very well known in his unique technique about tactile control activation. So I'm here inviting you. If you don't know what is tactile control activation, just search for it. You will find a lot of cases. You will find a lot of literature speaking about it. But today we are not going to speak about tactile control activation. Today we are going to speak about a case that he recently published, and it's an interesting case. It's about density. So in order to save your time, my friend, in order to save the time of all our audience, this is your screen is already ad, and we are all ears just to listen from your side about the case. You can share, you can start the review, my friend.
Thank you, my dear. So I will start my presentation about the case of a dense indent, an interesting case that I selected.
Sorry, my friend. Just before starting, I'm sorry to interrupt you. Just I want to be sure that there's no problem in the sound.
Everything okay?
Someone, Mr. Zahir, Dr. Zahir said that there's a problem, but I can hear that the voice is clear. Can anyone just give me a hint? Give me a hint from the people that are clear. Okay, Mazen Dumani. Or regards for our partner, by the way, And this series, Dentistry Online group, it's already now broadcasted on the Dentistry Online. So, my friend, we can start. You can start. Everything so far so good.
Okay.
Sorry
Okay.
for-
Perfect.
Yeah.
So, although I developed the tactile control activation technique to be able to manage highly curved canals safely and predictably, for this course, I selected a completely different case to discuss with you. A case of dense indente type 3, according to Eller's classification, that actually you will see it's a very difficult case, and it's a case that actually we cannot create shape during our attempt to clean the root canal system, because the root canal system is so complicated that there is no chance of us creating a perfect shape inside so that we can fill the case. So let's start.
Let's start.
According to Eller's classification of dense indente cases, this is the most common classification used worldwide. We have 4 types of dense indente, and the type 3B is the most difficult one, when the vagination goes all the way to the apical third of the tooth in the center of the root, and the whole tooth is invaginated. So this is our case that we are going to discuss. This is a patient that is 14 years old. He was referred to the clinic with pain and swelling in this lower right mandibular molar. The first thing, when you can see by going through the periapical radiograph, is that it's obvious that this case concerns a dense indente case of type 3B according to Eller's classification. And whenever I have such a difficult case, I always would like to have a comb-in CT to tomographic image so that I can plan my treatment. So here I made...
If you allow me, before starting and to see the complexity of the case through the CBCT, I have actually 2 questions. As you mentioned that it's a 15 years old patient came to you suffering from this swelling and this necrosis, as we can see. The first thing, how much we can face dense indente during our practice, according to literature, as a percentage. So how much we can expect the teeth as a percentage?
It's relatively rare malformation, around, it's mentioned in the literature, from 2 to, in some cases, in some papers, 20%, but we can find this malformation most common in the lateral incisor, maxillary lateral incisor teeth. In the mandibular, premolar teeth is very, very rare to find.
Very rare, yes.
Very rare, especially this kind of invagination, that if you allow me, I can continue with the video. So I find in this kind of cases, I find very useful the axial slices of the comb-in, because they are going to guide me how to negotiate this very challenging anatomy of this tooth here. So if
let's see the CBCT, and then we'll continue discussing.
As I move in the axial slices towards the apex, you can see that I have some different spaces around the invagination. Then I move a little bit more apically, and you can see here the enamel of the dense indente. And then as I move more apically, I can see a big space surrounded by a semilunar space. And this is the other dimension that you can clearly see how these spaces communicate with each other inside these tooth. When you are facing a tooth like this, the first thing is, the first problem is, what are you going to do? How are you going to clean the infected root canal system in this case? I mean, it's a case that actually access is difficult. You cannot really create a shape that you can predictably obturate. And how are you going to clean this complicated root canal system? So,
my friend, what do you think the cause for, what do you think that causes the bulb death and the necrosis? I cannot see any caries.
Yeah.
What is why we have this?
I will move to the next slide, that is the clinical image. This is the tooth. If you can see my pointer here, usually in this kind of teeth, we have the entry of invagination in the occlusal surface, that after grinding the cusp there, you can have a point of entry of bacteria inside the invagination. So usually it's in cases like this, a slight grinding of the cusp can be enough to adequate to allow bacteria enter inside this tooth. So
about this, my friend, do you advise the following? For example, if we can see for a routine examination, we have a patient and we make an X-ray, and by incidence, we discover that this patient has a dense indente. Do you advise to apply some sealant, to do some etching and sealant from the beginning, just as a prevention?
Yes, I think it's a great preventing measure to apply some sealant inside the little fissures and the possible portal of entry of bacteria, in order to prevent this from happening. Unfortunately, this tooth now is completely necrotic. It doesn't respond to vitality testing. The patient came with its percussion, painful, and a swelling. So this is a video for you to see what I saw. This is the occlusal surface. Probably the point of entry is the exposed dentine over here. The enamel is where the dentine is exposed, and through the dentinal tubules might be a possible portal of entry of bacteria, the necrotic tooth. So actually what I did here, I start gradually to access the complicated canal system, and you see here pus is coming, is draining
very clear.
Very clear through the tiny access cavity. I'm leaving the tooth to drain, and now I'm keeping in one monitor the axial slices of the cone beam, and under my microscope I try to get proper orientation and try to negotiate all these infected spaces inside. Of course, in the beginning you have a lot of pus draining. It needs time to, after adequate drainage, it will be hemorrhagic drainage, and then you are ready to move deeper and deeper. I will move the video. Now you see hemorrhagic drainage now, and irrigate, try to clear all the necrotic tissue and the pus, and see how you can achieve proper orientation inside this complicated anatomy. So actually what I'm doing in a case like this, I use ultrasonic diamond tip to go deeper. And I have in one monitor, you will see that in one monitor, I will have the cone beam. You will see now here that I have the axial slice, and I try to replicate to enter the spaces. So right now, this is the axial slice of the cone beam, and this is what I get under my microscope. At this level, you can see that
great. By the way, it's a great, just very, very, very important top, very clinical tip for our audience, just to work simultaneously while we are moving with the slices of the axial and also noticing the reality. It is very good idea in order to calculate and to know where is the hidden anatomy.
You can use one monitor for the axial slices, and the other is the monitor of your microscope, and get proper orientation and try to negotiate the spaces that you can see in the cone beam. You see the resemblance is striking. I mean, the cone beam gives us the information we need to negotiate all the spaces we need to clean them. So by moving deeper inside, now let me go a little bit back just to show you here that at this level of the axial slice, this is the point that I need to drill through this to get inside the belly of the densindente. That is actually a densindente is a pregnant tooth. So I have one tooth inside another tooth. So at this point, you can see the pulp, you can see the roof of the densindente. So actually, I have to drill around here in order to negotiate this big space. So this is what I did. This is the periphery, and this is the invagination. I entered now. Now I'm using the round diamond burr with my ultrasonics to go deeper and smoothen the edges. And now you know you have two compartments. Actually, in a case like this, you cannot create shape with your rotary files or hand files. So how are you going to clean interconnected spaces like this? The best thing that I could think for this case, look at that, is to insert an irrigation needle inside the invagination and then connect my needle with an adapter to the high-speed suction of my unit. Here is the high-speed suction, and this is my irrigation needle that it's evacuating sodium hypochlorite. So this is the high-speed suction in the center inside the invagination. And then I go with another needle with positive syringe irrigation in the periphery of the invagination. And actually what I'm doing, I'm injecting sodium hypochlorite on the outer wall of the invagination and evacuating the sodium hypochlorite through the invagination. And let's see how this is done. You see, injecting sodium hypochlorite, and sodium hypochlorite gets evacuated by the needle that is fitted deep inside the apical third. So it's, I'm trying to create a constant flow of fresh new irrigant through around the whole spaces in order to clean this challenging system, canal system. Actually, it's not a canal, it's intercommunicating spaces.
Yes, of course. Yes, yes.
Okay.
Yes, it's interesting that what you are doing actually it's like a negative irrigation, but here in this negative irrigation you are directing the suction in the invagination in the baby tooth, let's say the baby tooth inside the tooth, and then you are injecting in the periphery the irrigation solution. So it is suction whether on the walls of the canal, whether at the end of the invagination. So you are trying to clean everything all around. And it's very interesting, by the way, that you try to penetrate the baby tooth by the ultrasonics. It is very good idea. And I want to ask you, can we use, like for example, Munzberg or LN burrs in order to penetrate this deep area?
Actually, we can use, if you have enough space, in order to use long-shafted birds, you need to have, you see some activation of the irrigant here, and in the video as I leave it running, but you know, with ultrasonics under the microscope, you have great, you have enough space and visibility that you need to manipulate your ultrasonic tips. With long-shafted pairs, you can have a visual corridor to see what you are doing, but actually you cannot achieve easily, especially in the mandibular teeth, proper orientation of the bird. And it's a little bit risky because you don't have space not to, it's a little bit risky to perforate in the wrong position.
This is the importance of ultrasonics. This is the importance of ultrasonics.
This is the importance. It's very focused preparation. You can guide your ultrasonic tip to the exact position that you need. You see in the cone beam and you see under your microscope without having anything blocking your vision or deflect your instruments towards perforation side. So you see here, I'm reversing also the flow of the irrigant, and actually, after cleaning, let me go back, after cleaning these spaces that I used sodium hypochlorite, but I used also warm sodium hypochlorite in 50 degrees, 45 to 50 degrees, heated sodium hypochlorite. If you heat sodium hypochlorite, you increase its dissolution efficacy, and also what actually you are doing, you are lowering the viscosity of the irrigant so that the irrigant can flow even in tiny spaces quite easily through this continued flow of fresh, new irrigant, heated irrigant all around the complicated system here. And actually, I used the same technique to obturate. So for obturation, which is a problem, I tried to use also the same technique. I fitted a capillary tip inside the baby tooth, in the belly of the baby tooth, connected it my high-speed suction, and with this orange capillary tip, I inject bioceramic sealer in the periphery around the baby tooth, and then I could see that the inject from here bioceramic sealer, and then you will be able to see that the bioceramic sealer is getting evacuated by the belly of the dente. And then what actually I did, I injected a mass of gutta percha inside the belly just to use it as a plugger to push everything and adapt my bioceramic sealer in all the tiny spaces around the
So you are using advanced hydraulics here. Here
Yes.
you are using advanced hydraulics to get benefits of the warm injectable getaberka in order to push more. So you inject in the periphery, you suction in the center, you inject in the periphery, you go back in the center and you push in order to also close everything in the periphery.
Creates hydraulics, as you very well said, and close everything. Then you can you can clean the bioceramic sealer easily with continuous water irrigation. You can use your ultrasonic also together with continuous water irrigation, and restore the tooth. This is the final restoration, and this is the final result of my effort. And here you can see before and after what was the result. And I will finish by showing you this radiograph was taken last week. It's 8 months follow-up, and you can clearly see that we have almost complete healing of the huge periapical lesion, and everything looks great clinically. So
really great.
I was very satisfied with this case, and sometimes we have to think outside of the box in challenging cases that we actually cannot follow the basic cleaning and shaping principles, because the anatomy is so complicated that actually you need to find another way to address the infection here. And the way I could think in this case was to try a non-instrumentation technique with continuous flow of fresh, new, heated sodium hypochlorite through all around the interconnected spaces. And the result was very, very, very rewarding in this.
Yes, it was very, very nice. Very good case. And actually, and this will open our eyes again for the non-instrumentation endodontics and the future holding about all of the irrigation units that are only trying to irrigate with minimally invasive. As you can see here, nothing was prepared, no instrumentation on the periphery, although we can see a start of a healing. Okay, my friend, I think you are done with the case. Just to open some discussion with you, you are done, okay? So
yes.
we will remove, we go back to see each other clearly more. You can stop sharing if you want, my friend. The question now is it a single visit root canal treatment? Why you didn't make it in multiple visits, for example?
No.
Just to be sure.
Maybe I didn't say that it was a multiple visit treatment. Actually, this treatment needs a lot of planning before accessing the tooth, and you need to follow very to follow a stepwise approach to approach all the spaces, the tiny spaces, and figure out how you are going to clean. And this kind of interconnected spaces, I always like inside the internal anatomy of human teeth, whenever I can find interconnected channels or spaces to create this negative pressure irrigation flow. And if you think about it, there are a lot of cases that we can find interconnected channels or spaces in endodontics. Let's say like in the mesial root of a normal mandibular molar that the two canals are joining. So, you can hit the capillary tip in one and inject sodium hypochlorite in the other, and you can have continuous flow with high velocity of fresh new irrigant, cleaning the isthmus, cleaning all the interconnecting spaces.
Yes.
And
especially a lot of ramification inside, of course.
And of course, you were able to see in the videos how easy it is to use ultrasonic tips under the microscope. They give you space to work in the exact position that you want your tips to work. Long-shafted bears sometimes are very useful. However, you need space to use them. And in the posterior teeth, by definition, normally you don't have enough space, and you don't want to, because of space restriction, to have your bear deflected towards a perforation. So the more I go towards the posterior teeth, the more I go with ultrasonic tips to be able to do what I need to do.
One last question, my friend. It was very interesting 30 minutes, but one last question. In such cases, or sometimes if you don't find this, or you will not be able to work with this way, and you will not be able to insert your tips and to do the irrigation, can you find a bariapical surgery an alternative treatment plan for such cases or not?
Depending on depending on the location of the tooth, usually this kind of teeth we can find dense indente in maxillary lateral incisor or central incisors, and the surgical access might be easier than going through a orthograde approach. So yes, sometimes I could even try to go since the beginning surgically and clean and shape and clean and obturate with bioceramic the root canal system from below, in order, especially if the crown is intact and I need to drill through a lot of calcified crown tissue to find the different spaces of the invagination. Maybe this is too destructive for the tooth, and it will be easier for you to go in a surgical approach. In the maxillary anterior teeth, usually we don't have problems. Yes. We just raise a flap and you can see the whole anatomy and try to treat it surgically. But in mandibular, yeah, it's very difficult. It's very difficult.
Okay, so, my friend, thank you very much. Really, we learned a lot from this very nice, very clever, open-minded, thinking out of the box case. Really, I thank you very much for allowing me for this opportunity to share this case over my page, and for all the audience worldwide to see this, how much you were clever in such treating such case. Thank you, my friend Antonis. I will leave you now, and I will try to do some summary in Arabic language for our participants for 1 to 2 minutes, and I really thank you very much. And actually, we had some questions I would like to ask you, if you have a time, to go over the page and to answer them, if you don't mind, to answer them, and it will be to get the optimum benefits. Thank you again, my friend, and hope to see you soon.
Thank you all for being with us.
Okay. Thank you. شكرا كثير للدكتور أنطونيس شانيوتس لهالفرصه الحلوه. ولاحظتوا كيف انه نحن الدكتور أنطونيس تعامل مع الحاله بذكاء، كيف قدر انه هو يستعين بالسي بي سي تي لحتى يقرا الاناتومي. ونقطه كانت كثير مهمه انه هو كان عم يشتغل سيمالتينيسلي، يعني هو عم يحاول يدخل بالاكسس كافيتي، وبنفس الوقت كان هو عم يشوف السي بي سي تي ليفل باي ليفل، وعم يقدر يقرا الاناتومي. اشتغل بالالتراسونيك وحاول يفتح البيبي توس اللي هو جوات الدنس اندنسي. بس بحاول برجع شوي معكم لورا، انه هو السبب غالبا بيكون بسبب الميازيب التطوريه، الانفاجينيشن جروفز اللي هي بتكون على الكاسب تيبس، اللي هي بتكون مسار للبكتيريا. يمكن شويه اهتراء بيصير على العض، على المضغ، فبتنفتح هاي المنطقه فبتدخل. فلا تنسوا انه هو هذا المدخل. لذلك اذا شفنا مرضى وعندهم دنس اندنتي ممكن نحن نعمل معهم معالجه وقائيه انه نحط سيلنت على الاسنان من البدايه. اذا فتح الحاله، خلاها تصرف، ارتاح البيشنت، رجع دخل للسن البيبي توث وحاول يفوت جوات القناه المركزيه وحط سكشن. الفكره الاساسيه تبعه انه عمل اريجيشن، عمل سكشننج بكنال وعمل اريجيشن بالبريفري. فهو كان عم ياخذ الفريش صوديوم هايبوكلورايد وعم ينظف الوصله ما بين الكنالز بدون ما يحضر البريفري. هي اللي كانت كثير كومبليكيتد على الاكس راي واكيد حتكون صعبه بالانسترومنتيشن، واساسا هي مش كنال، هي صراحه سبيس اول اراوند بحاوط البيبي توث الموجود جوا. وبنفس الوقت بعد ما نظف وعقم وراحت السيمبتومز عند البيشنت استعمل نفس الطريقه اللي هي نيجاتيف اريجيشن بس from one canal to another، وحط السيلر بايو سيراميكس، نعرف فلوبيليتي على الماتيريال كيف تقدر تفوت. وبعد ما اخذ السيلر وشافها من القناه المركزيه لما حقن البايو سيراميكس بالبيريفري حط جتابيركا وحقنهم بالمركز ورجع رجوع لحتى يعبيه. صراحه يعني كثير كليفر. بنرجع بنقول الاندو هي متعه، لما الواحد بيتفرج ويشوف بيصير بيفتكر وبيبتكر حلول. كانت هي حاله الدكتور انطونيوس شانيوتس، بتمنى انه تكون استفدتوا منها وحيجاوبنا هو ان شاء الله على الاسئله. ودائما دائما بقول لكم يعطيكم الف عافيه. شكرا دكتور مازن دوماني على كونكم الشريك الرسمي لنا، وبنشوفكم بحلقه ثانيه وبنشوفكم بشهر جديد ان شاء الله مع كلينيك الكيس وضيف ايضا مميز. ودائما بقول لكم دائما لا تنسوني من صالح الدعاء، ويعطيكم الف عافيه. طلال النحلاوي.